where does a cow get its strong bones from? You ever wondered that question? It's eating a ton of grass, right? You gotta extract these trace minerals from things that concentrate them for you. And in our current culture, where everything's processed, where the cows are eating grain, they're not eating grass. We're causing massive deficiencies of these trace minerals that there's about 98 of them that you need for your bones to be healthy.
If you haven't done so already, go ahead and click that subscribe button down below. It's a little red button. You punch that, and it's going to notify you every time we put out a new episode that can help you improve your bone health. And then also, if you haven't done so already, head over to BoneCoach.com, sign up for the free 7-day Osteoporosis Kickstart. That's going to walk you through everything you need to be doing right now to get on the path to improvement and stronger bones. After you do those two things, go ahead and press play on this episode, and I'll see you inside. Welcome to this episode of the BoneCoach Show. Joining us today to explore hidden causes of osteoporosis, metabolic syndrome, and so much more is Dr. Aaron Hartman. Dr. Hartman's journey with functional medicine started when he and his wife adopted their first daughter from foster care. She had cerebral palsy and countless dietary issues. They went from specialist to specialist, and even as a physician, he felt let down and confused. His daughter's health struggles forced him to confront an uncomfortable realization. Our current healthcare system doesn't have all the answers. His wife, however, refused to give up hope. She ultimately pointed him to functional medicine. His daughter and other two kids began to thrive. After years in family practice, he felt called to make a dramatic shift. He now helps patients identify leverage points in key areas of their lifestyle and health that harness their body and remarkable power to heal and begin living the vibrant life they deserve. He's become the go-to doctor for difficult and hard cases in Central Virginia. As a clinical researcher, Dr. Hartman has been involved with over 60 clinical studies. He's the founder of the Virginia Research Center and currently is serving as an assistant clinical professor of family medicine at the VCU School of Medicine. In 2016, he founded Richmond Integrative and Functional Medicine. Dr. Hartman, it is absolutely a pleasure to have you here. Thanks for being here today.
Kevin, thanks for inviting me. It's great to be here. I'm just excited to talk with you about osteoporosis and all the new and interesting things about it.
Well, let's get into it. But before we get into it, let's talk about how you took this journey, through your kids' health all the way to you making this transition into a more functional approach. And then also being behind so many different studies and really getting an understanding of how to help people resolve their health issues.
Well, I think, my wife is a pediatric occupational therapist. And so her specialty is kids with special needs. And so when we first got married, she'd always talk about cases at home. And I was just like, that's kind of weird. Never heard about that before. Right. And so one day she was like, there's a little girl that needs a home. Would you think about bringing it into our house? And so we brought Anna in and ended up adopting her. And one of the first struggles was like, she has cerebral palsy, and kids with cerebral palsy tend to be small. And so the GI doctor was, hey, I got to fix. You got a small kid, let's put a feeding tube in, pour some formula down, problem solved, right? And it was just it just didn't feel right. Like I wanted, even though my daughter was never supposed to walk or talk or crawl, I'm like, look, we have a bigger vision, bigger hope for her. And so putting a feeding tube in will affect her ability to, you got to chew and swallow to learn how to talk, right? You have to actually be able to crawl, and the tube just blocks that stuff. And so we opted out. And the thing that really cut my light bulb on for this, so to speak, was 6 months later, my wife found a growth chart for kids with CP. My daughter was right in the middle. The specialists had no idea that there was this growth chart for my daughter. My wife had to find it, and they were going to do a surgical procedure to her to make her gain weight. And she was actually right in the middle of where she should have been. And that was the first, an inch at Cape Canaveral was like a mile at the moon, right? And that was my first like, whoa, I'm going to start questioning everything. And we did it over and over with my daughter. I started learning things. We got into functional medicine. And all of a sudden I was learning all these new things. I'm like, wait a second, let me try this with patients as well. So I started applying with patients and seeing amazing results with their health. And so that's what kind of got me off the pathway. And, I'm always learning. I'm a lifelong learner. In 2010, I'm like, hey, I got this great practice. Let's do clinical research. We started doing that. And that was really cool because I got to start seeing what was coming out in the pharmacology, new drugs, new vaccines, new stuff. I was at the front end of that and starting to see where is the industry going. And it's kind of cool because sometimes you see it's going in a good direction. Sometimes you see it's going in a not so good direction. It also helped me appreciate how studies many times are leveraged to get certain outcomes. And so you really have to dig deep. It's really crazy to think that half of the findings of all clinical research, the findings are later found to be false. And one of the things that opened my eyes to that was actually being involved with it, just to see how the things are written, how studies are designed. They're designed to get a positive outcome. And you really have to have a really keen perceptive eye to pick that up. And that's what I kind of learned over 12 years of doing clinical research.
Well, I'd love to even just talk about and understand a little bit more and share with our audience, what are the different types of studies? How are they structured? Like, what's the actual different levels of research that are out there?
Well, there's a whole host of different kinds of studies. When people say evidence-based, they're referring to one specific type of trial, which is a randomized, double-blind, placebo-controlled trial. And so in those, you have a placebo group and an active group. You have an intervention, and you basically try to limit all of these factors. Like you try to limit people that are non-compliant. You limit people with multiple health issues. You limit people who won't show up on time to their office visits. You basically eliminate most of the people I see in real life. And you create this kind of fake pseudo group of people. That's your active group and your control group. And that's the gold standard. And so you have to realize with the gold standard RTC, you're looking at one intervention, one outcome. It's not meant to say now cut and paste for the thousands of people you see. It's meant to say this one medication, one intervention does this one thing. You know, the original definition of evidence-based medicine was patient preference, clinical expertise, and data, right? And so we've almost changed it. Now it's only this special kind of data applies. So that's one thing. That's the quote unquote evidence-based medicine. So there's population studies, you know, hey, we've noticed that people who live north of a certain longitudinal line get more multiple sclerosis. Why is that? And so you do population studies to figure out, are there general trends, like the China study? You eat a certain diet, you have a certain outcome. The NHS, the nursing study looking at hormones, right? We thought hormones were great for women. Oops, they cause cancer. Oops, it's the wrong kind of hormones that cause cancer, right? And those studies are great to get data, right? For like, hey, hormones are good for women, but then you have to take a deep dive and do another research study, which was in the National Health, trial with women from Canada. You've got population, you've got epigenetic data. Like you look at populations, hey, there's less. Well, here's a great example. There's more colon cancer and gut cancer. There's more GI cancer in Costa Rica and in Japan. Why is that? So you see these little outliers, and then you eventually develop a randomized trial. And there's like clinical research, and this isn't the functional medicine where we use lots of this, where it's like early on, stage one, bench research with animals and mice, and stage one studies where this nutritional intervention, vitamin D, actually improves longevity in mice. Maybe we should try in humans, right? So there's different kinds of data we look at. And in my world, I look at all of them. But when people usually say evidence-based, they're only looking at one limited view of everything.
So that's the gold standard, right? That we want to look at. But then what are the other levels that are out there that people may be exposed to or be looking at on a daily basis? And
well, there's on people looking on a daily basis, they're usually looking at a lot of news feeds. They're looking at, for example, I did a little Instagram post on this. The CNN was reporting on a study from the UK saying popular supplement, can kill you. And it was vitamin D. And so people look at that and saying, hey, look, there's a study showing that. And it's like, yes, this person was taking 150,000 units a day of vitamin D and it killed them. Kevin, don't take that much, okay?
Yeah.
And so what most people are looking at are these news reports of studies of events, and they're taking out the cliffhangers, like the hooks, and they're not diving into it. And if you took that one particular one from CNN, which literally came out, right now we're recording this in July. It was literally the middle of July. They were looking at the recommended dose being like 600 units of vitamin D to stick with that. We both know that's not enough. Mm-hmm. So they're saying, don't take too much, take too little. And unfortunately, people are exposed to that kind of information all the time. And that's the reason they need good, reliable sources. Like in today's era of too much information, over information, too much static, and everything has to be a hook, has to be provocative. People just need reliable, dependable sources they can get stuff from. And unfortunately, what I see on a daily basis is misinformation being spread, being amplified. And they get to the point they're like, well, what are our options? What hope do we have,
Are there nutritional compounds that could be really helpful for different conditions, diseases, disorders that may never, end up getting the funding or the studies behind them?
Yes. So a great example that I'm sure you talk about all the time is vitamin D, And so when we have data going on vitamin D, I actually started checking vitamin D levels on my patients based on the data in 2003 and 2004. Even now today, almost 20 years later, it's still controversial according to the Institute of Medicine, right? Should you take D? So what happens in medicine, they wait for enough data that it's irrefutable. I usually tell people it took about 50 years and 7,000 research articles before the Surgeon General of the United States said smoking causes cancer. Vaping, when in 2004, I was being told by a pulmonologist, hey, vaping is a way to get people off of smoking, right? It took us 10 years to figure out, oops, popcorn lung, oops, brain shrinkage after doing it for 10 years. Bad idea, right? And so you just have to realize that's what you were dealing with. And it's hard when the implementation of good data could take half a century, for example.
Yeah, such a long time for us to really understand what's going on there. And then for you, so obviously you're in practice right now. You're seeing patients. You're still actively practicing. You see people coming in with different health conditions all the time. What are you primarily seeing people for when they come into you?
Well, in my office, I see a whole host of things, usually very complicated patients. I'm usually the fourth or fifth doctor they've been to. Lots of chronic fatigue, lots of fibromyalgia. I'm seeing a lot of people with hypermobility spectrum disorder, which is a lot of your athletes that are double jointed, but they have a concussion, they have an injury, and now they've got mold issues or Lyme issues, a whole host of things. And that's probably one of the big things I'm seeing right now. That's probably the new kind of quote unquote zebra in the room that's everywhere. There was this UK study looking at kids. 20% of kids in this pilot study were hypermobile. Well, all of a sudden it's a big deal because hypermobility increases your risk for osteoporosis, osteoarthritis, fractures, injuries. It's associated with a whole host of things, bone health, connective tissue health. And 1 in 30 adults in the United States have this thing. So that's one of the things I'm seeing all the time, because obviously my population is unique. I'm seeing people that have a lot of health issues. I'm not seeing elite athletes, which would be a totally different set of people. So.
And why are those conditions contributing to osteoporosis and bone loss?
Well, ultimately, osteoporosis is a metabolic condition. It falls under the rubric of metabolic syndrome. And so you have to think about the bones are an active part of they're an active organ. It's not just hard, thick calcium that doesn't change. It's actually active and living and vibrant and moving. That's the reason you can break a bone. You do an x-ray 6 weeks later, you can already see it healing. 2 years later, it looks totally normal. Every 17 years, your bones turn over. You have new bones now you didn't have 17 years ago, Kevin, right? They're all brand new. And so it takes an active metabolic organ to do that. And so what we see is other things in this thing that are associated with diabetes, high triglycerides, gout. It's interesting. Elevated uric acid, for example, is a metabolic syndrome. PCOS, polycystic ovarian syndrome, is a part of this. Sleep apnea, which is crazy, crazy common. That's going to cause, and all these things cause inflammation. And osteoporosis is one of the many things that fit under this rubric of metabolic syndrome, that if you're inflamed, that's going to affect how your bones heal, how they repair, how quickly they turn over. And then when you get into the age in the late 30s, early 40s, if you're a female and your estrogen starts coming down, you kind of lose your superpower that keeps things going, allows you to do all this crazy stuff. And now all of a sudden, your bones start getting a little thinner because your nutrition is not quite right. And all of a sudden, you're in your 50s and 60s with osteoporosis.
And what are the most common secondary contributors to osteoporosis that you're seeing?
The most common, the number one's gonna be vitamin D deficiency. I mean, people forget vitamin D is a hormone. It's a hormone of calcium metabolism is the first thing, but also modulates your immune system. And so low D is going to affect how and where your body puts calcium. So if you don't have adequate vitamin D, guess what? You won't put it in the right places, like teeth, like bones. You do need calcium also in your neurons to transmit neurological symptoms. But the other nutrient that a lot of times will replace is vitamin K. Well, if you don't have the right kind of the right amount of vitamin K, the vitamin D won't help your body put it in the right places. And what we learned back about 3 or 4 years ago, we had a study come out. If you take just calcium and you're a female, the calcium goes in the wrong place. It goes in your heart. So all of a sudden, taking calcium without the other things can cause a lot of issues. So, vitamin D, K, there's a little calcium thing. And then trace minerals. We have a huge deficiency of trace minerals in our country. We stopped eating bone broth. We stopped eating real food. We're eating processed foods. And your bones are not just calcium and magnesium and phosphorus. There's silica, strontium, barium. There's a whole host. Strontium is this one interesting mineral that if you actually by itself actually can help reduce the risk of osteoporosis. And where we naturally get these trace minerals is from other animals that concentrate it for us. And so if you're not doing bone extracts, bone broth, where does a cow get its strong bones from? You ever wondered that question? It's eating a ton of grass, right? You got to extract these trace minerals from things that concentrate them for you. And in our current culture, where everything's processed, where the cows are eating grain, they're not eating grass. We're causing massive deficiencies of these trace minerals that there's about 98 of them that you need for your bones to be healthy.
Obviously, you've kind of made this transition into functional medicine, and you're focused more on root cause approaches and things like that, but you're also, a medical doctor. Do you find that other medical doctors don't necessarily have as solid of an understanding of the nutrition components or different nutrients component as maybe somebody that's more functionally trained?
Well, think about it. I've got 3 board certifications. My first was just family medicine. And I learned none of this in my hospital training and my outpatient training. I had to go into integrative and holistic and functional and metabolic training to get all this stuff. And so it's just not part of our training. Unless you have a reason to get into this, you're just not going to know it. And when someone comes in with osteoporosis, we have certain medications we can treat them with. And that's you. It's not a buffet. It's a few limited things. Your bisphosphonates, your PTH antagonists, calcitonin, and then, taking calcium. For a while, we were telling people to take calcium. And I don't know if you've talked about this on your show before, but like for decades, we're saying calcium, 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 calcium. And then 3 years ago, oops, just calcium by itself increases a female's risk for cardiovascular disease. That's happening all the time. That kind of stuff is happening all the time. And so one of the things, the way I think, what's the next smoking? What's the next vaping? What's the next thing I'm telling people right now? I'm being told to tell people that's 100% wrong. I take first and foremost, do no harm very seriously. Mm-hmm. And so I think in many ways, we give lip service to that and we don't take it like, what am I doing now for patients that actually might cause harm and what won't cause harm and what actually can be beneficial and helping people figure that out. And these are things we're not trained in school to do.
And that's great because, when I hear a lot of people come to me and they've got osteoporosis and, I'm asking them, what's been the recommendation that's been provided to you? Calcium, vitamin D, go for a walk, take a bone drug. And even if somebody were to just do the first 2, calcium and D, right, you're still not going to have the other nutrients that you're going to need to get those nutrients where they need to go and to make sure that you're supporting your body in a right way and not causing additional harm to yourself. So great point.
And there's probably a lot of your people listening to this podcast right now that still haven't heard about the whole thing. Calcium by itself is no longer recommended by the AHRCQ. It's just not recommended. Mm-hmm. And no one's pushing that because it just doesn't sell. And it's like, oops, we're wrong for literally a couple of decades,
Yeah. And then in terms of some of the other contributing factors, one of the things that comes up with me is, I was in the military. How would chemical exposure and things like that, how can that contribute to bone loss, bone health, osteoporosis?
Well, it's, your bone is a metabolically active organ. So things that mess up your metabolism, they're called endocrine disruptors. And so those things will mess up your hormones, mess up your bones, mess up anything in that whole metabolic syndrome, increase your risk for cardiovascular disease. If you're in the military, increase your risk for diabetes. Just being in the military by itself, there's an increased incidence for Parkinson's and ALS. Why is that? Chemical exposure. I was a physician in the Air Force for years, and it was amazing. You see people come back from Iraq, from overseas, and people are tired and fatigued, and they have all kinds of issues. And you're like, well, that's kind of weird. Like, what happened? And then you were breathing burning trash for a year. You're breathing burning tires. You're on the flight line breathing burning diesel fuel. And all of a sudden, it's like the light bulbs start going off. Wait a second. People in the military are exposed to a lot of stuff. And it's interesting how that can actually affect your bones. And we see the same thing with women, young girls putting on these things on their bodies that mess up the hormones called endocrine disruptors. No one thinks about what that's going to do to them 40 years later. So it's really intriguing and concerning all at the same time that we actually know about this now and no one's talking about it. And we're still exposing our service people and our young daughters to these things that 40 years from now they're going to be bad for them.
What's interesting is when I used to go out on patrols and things like that, and we'd have dust storms that would come through, and some of those things we would just be breathing in, all this disgusting, horrible dust and stuff that was kicked up. And I always wondered, I was like, that's probably going to the lungs and is going to be resting there for a little while. So probably not the best thing. And then in terms of what you were just talking about for our kids or any of us, really putting things on our skin that can be disrupting our hormones, if it's got like a perfume scent to it and it's not like essential oil based, that may be something that's actually contributing to hormone disruption as well.
The average female puts about 200 chemicals on her body every day before she leaves her house. That's a crazy thought to think. And a lot of these are these things called neuroendocrine disruptors. And part of what I do in integrative functional medicine and the way my philosophy is I look at like what happened in the past. What can we learn from the past? And one of the things I look at, for example, in the United States in the mid 1800s, the average female started her cycle when she was 16. Okay. When I was in high school, the average female started her period when she was 14. When I was in medical school, I was told 12 was the new normal. Now with young African-American females, starting your cycle when you're 9 is considered typical by the American Academy of Pediatricians. So we've dropped 7 years. Like, what does that do to your bones when you're older? What does that do to your health when you're older? What does that do to your risk for breast cancer? It was when I was in my training, seeing a 30 or 40-year-old female with breast cancer was so rare. All the interns would be shown it. Now, like my wife has friends in their 30s and 40s with breast cancer. Like, what are we doing? And it's interesting. You got to wonder with these chemicals that act like hormones, how is it adversely affecting the body, bones, heart, brain, all these things? It's concerning. And unfortunately, a lot of our experience with this comes from military people. We do a great job collecting data on what we did to people in the military in the 40s and 50s in Vietnam, and now we're literally doing similar experiences to our population at large with chemicals.
I know a lot of people come to you because they've already seen, 4, 5, 6 people, maybe more than that. And you're the one that's really helping them figure out complex health issues. What are some of you mentioned some other conditions earlier, hypermobility spectrum disorder. You also touched on sleep apnea and some other ones. Can we just walk through and help us understand what are some of the most commonly overlooked conditions, diseases that increase the risk for osteoporosis? And then when you identify those things, how are you helping people work through those? Okay.
I'll start with sleep apnea because that's something I see all the time. And I've seen a lot of slender females that are hypermobile. You might be slender, athletic, your double joint, the elbows, et cetera. And I won't go through all that, but what happens is you don't make collagen quite as well. And you need more vitamin C. You need more trace minerals. All of a sudden, you need more collagen protein, these things that our diets are already low in, right? You need more carnitine. You need more of all this really kind of cool stuff. Well, if you have someone who has a higher need of this, and they're not getting it adequate, all of a sudden you set them up for issues with the connective tissues, including bone health. They also have a high risk for sleep apnea. I call it skinny people's sleep apnea. It's not that I've got it by the way as well. Got my skinny little size 15 neck here. I've got mild sleep apnea, and that causes inflammation. It's part of the metabolic syndrome thing. Kidney stones, and I'm here in Virginia. I'm in the stone belt. Kidney stones are a very common thing. You get calcium oxalate stones. Well, that's a marker for yeast overgrowth in your GI tract. Well, how many women have heavy periods, fibrocystic breast issues, PCOS kind of stuff? One of the things that drives that is estrogen dominance, which can be driven by gut issues. And so we'll look at their kidney stones and say, hey, you've got these oxalate stones, but no one says, why do you have too much oxalate in your blood? Are you eating it or making it? And we say, remove oxalate foods is like, great, you're still getting stones. Why? Because you have yeast overgrowth, which is affecting your hormones. And now you've got kidney stones. Oh, by the way, osteoporosis is in the same world with this. And so all those things, I kind of walk through all of those things. If I see someone with osteoporosis, I take a step back and say, which of these other metabolic conditions could be going on? Did you have PCOS when you're younger? Do you have fibrocystic breast now? Do you have sleep apnea? A lot of times people jump to giving hormones, which, the best thing for bone preservation is estrogen. I mean, there's no way around that. But if you don't have everything else in check, the diet, nutrition, gut health, sleep, all this other stuff, hormones only will help so much.
And in terms of, some of the other conditions that you see, you mentioned sleep apnea, hypermobility spectrum disorder. Are there any other ones that you get frequently? You're actually one of the first people to ever talk about how your body produces oxalate as well. It's not just from the foods you eat. Like you can actually be producing oxalate on your own.
Yeah. And so, well, that's a different, you can't, like we see a lot in kids that are autistic, actually have high oxalate levels from yeast overgrowth in the GI tract. But in the other things, like if someone has high triglycerides, for example, in metabolic syndrome, high cholesterol, we ignore all your triglycerides are 200, 300. your HDL, if you're a female, your HDL is 40, that's low for a female, Well, yeah, I realized that if you have these numbers are off, that's telling us your peroxisome, which is a little organelle into your cells, is not functioning appropriately. If it's not functioning appropriately, it's not just affecting your cholesterol, it's affecting your bones. Diabetes is another thing that falls into metabolic syndrome. I mean, glucose is toxic to every tissue in your body. If it's too much, it's toxic to your brain, your liver, you get fatty liver. It's toxic to your kidneys, you get kidney disease. It's toxic to your bones. So all of a sudden, checking fasting insulins on patients, A1Cs, is a way to say, are you having insulin toxicity? I haven't mentioned yet thyroid function, because I feel like that's probably something people have mentioned already on your show, because it's like the one people jump right to.
Go for it. You can still bring it in here.
Well, it's like this doesn't fall into the metabolic thing, so to speak, but your thyroid is your primary hormone for your metabolism, right? And you might have a quote unquote normal thyroid, say your TSH is 4.9, your free T4 is 0.98. It's subclinical hypothyroidism, but you don't complain about being tired and fatigued, but you have osteoporosis. This is an important hormone for entire function of everything in your body. Cortisol, high cortisol can actually push up your sugars, but high cortisol also is catabolic. It can cause bone breakdown. If you're a high stress, high cortisol person with sleep apnea and kidney stones, everything else, it's like, okay, let's work on these things. And all these, ultimately, your bones are a huge metabolic organ in your body, and you have to look at it holistically. You can't just say your bones are thin, take calcium, take your Fosamax, take your PTH, whatever, and lift weights, and you'll be fine. It's interesting how poorly that stuff works. Actually, if you do those things, they don't work that amazing.
Are there specific things when people come in to see you that, as part of your workup, do you have a standard approach or protocol or something like that you go through and walk every single person through? Or is it, obviously there's some nuance for individual needs?
Yeah, what I do is very personalized. I mean, I have a standard process. Like I go through your past history, where you grew up, your birth history, when you first started your cycle, when you went through menopause, did you have any hormonal issues, gut issues? I mean, one thing I mentioned yet is your gut health, IBS. IBS falls in the metabolic syndrome as well. We didn't even mention gut health and bone health, So I have this set of questions I go through with all my patients. And then based on that, will determine what testing I do. I pretty much always do nutritional testing. I pretty much always do fatty acid testing and cholesterol testing and inflammatory markers. If you're inflamed, if your sed rate's up, if your CRP's up, I mean, you're inflamed. You've got lots of issues going on, so that's kind of like my standard kind of evaluation and protocol, so to speak. But then if you say, hey, by the way, I'm a slender female that played volleyball and swam, and I've got premature hand arthritis, I'm like, are you double jointed a little bit? Huh. Ooh, you've been deficient in these nutrients forever. Oh, by the way, I had early surgical menopause. I had really bad fibroids and et cetera, et cetera. I had a hysterectomy when I was 35, or after I had my third child. I'm like, you went through menopause like 15 years early, right? And so I'll take my general approach, and as I get the history and I'll talk to people, then I'll kind of individualize it a lot more. But I think that the foundational things are foundational, diet, stress, sleep, exercise, nutritional status, relationships. Like these are all the standard things you got to do with everybody. And then as you go into someone's history, you find what's unique for you, Kevin, about your history. Like you talked about your stuff before, about your bones and your military experience. Ooh, I've got a lot of things in the back of my head with detoxification and cyanotherapy, because you still got toxins probably from your days back in Iraq and et cetera, et cetera. Like, let's work on that as well while we're doing all this other stuff. And so that's where having a really broad approach, having a standard way you do it, but then if you have a lot of tools in your toolkit, you can then dive down these different channels with people based on their own story.
And are there different things you do for people with osteoporosis too?
Well, absolutely. Because if you have osteoporosis, you're getting a very, what's your fat soluble vitamin level, D, A, E, K, trace minerals, zinc. People, you definitely need your magnesium optimal. You need your potassium optimal. People don't realize that potassium at 3.9 is not optimal. People don't realize that magnesium at 1.8 is normal, but not optimal. There's trace minerals, looking at selenium, zinc, all these things. One of the issues, however, is that the ultra trace minerals I mentioned, like strontium, lithium, silica, barium, all these things, there's really not good testing for it. So I just tend to supplement people with trace minerals who have osteoporosis. I kind of know they have issues with it. It's really interesting. Collagen, people talk about collagen a lot. People don't talk about the different kinds of collagen. Giving people skin collagen is great, but let's work on bones. Hey, you have other connective tissue issues like joint issues. There's different collagen in your joints than there is in your bones. So I tend to use a full spectrum collagen product to get it all. Because you realize it's really funny how many patients with osteoporosis, you look at their skin, they got skin issues as well, right? You look at their skin, it's premature ages, you got the little spots on it. You got those, and you're like, wait a second, your skin's kind of gives a little bit, you bruise real easy. What I'm talking about? It's like, this is not just a bone issue. And that's one of the things I do all the time is look at people's whole body and say, look, and you're shaking your head, the kind of person I'm talking about is older, and they got really a lot of photo damage. They got the big skin spots. They got like the sagging on the arms. They bruise easy. And it's like, you're here for your bones. You're here for whatever, your joints, your arthritis. This is systemic. And it's screaming at me right now when I'm looking at you, So those are some of the basic things. The thing I always have to individualize it. What's the person in front of me presenting as? And I tend not to do quote unquote protocols because I do a basic approach, but ultimately you lead and guide me. What I tell patients is I don't figure anything out. You tell me. Your story tells me, your lab results tell me how you respond to what we do. If we're trying something, hey, we put someone on bioidentical hormones and get the cortisol down. The bones don't improve. The telepeptide doesn't get better. I'm missing something,
Let's talk about that. Let's talk about measuring success. Right. Okay. And actually measuring improvements. So obviously, we can see improvements in different lab markers. And as we're talking about DEXA scans and bone density, that's one of the major things that people look at. But what are the other ways that you measure improvements in your patients?
So I'll talk about the DEXA scan really quickly. It's a hard measure when you have to wait 2 years to see how you're doing, right? And someone wants to check it again in a year, and they do it on a different machine, right? You got to do it on the same machine. It has to be the same machine. There's variation between machines. And you got to give enough time. If you do too soon, it's really funny. I've seen people get a little arthritis in a joint, and it goes up, and the other joint goes down. So you have to really know how you're interpreting things when you look at. So, and it's really hard to treat someone when literally, let's do this and check it in 2 years. So there's a bone turnover marker called an NT telepeptide. It's a marker that just basically is all right, you got two cells, osteoclasts and osteoblasts. One cell makes bone, one cell breaks down bone. So what tends to happen as you get older is that the cell that makes the bone does it a little slower, but the cell that breaks it down can be the same speed or speed up a little bit. So the NT telepeptide is looking at, are you breaking your bones down? Okay. And I'll actually will test that before I start treating people and see if it's high or low, whatever. And then we start things. We'll still do your DEXA scan in a year or two or whatever, but let's check this telepeptide level in 3 to 6 months. Is it coming down? Awesome. Great. That gives me a marker to look at, to say, are we going the right direction?
That's awesome. I love that you're talking about these bone turnover markers because they're so important as leading indicators, right? That bone density, that DEXA scan it's a lagging indicator of success. You don't want to be implementing something or thinking you're addressing something for a year or 2 years and then come to realize at that point in time, because that's your only measure, that you were doing the wrong things. And I'm sure that for you up front, if you notice somebody has something off, right, they get their lab results back, those levels are elevated, then it's like, okay, what is leading to that elevation? And then how do we go about addressing that so we can get you on the right path?
It's also nice when you're working with someone because I want to know I'm doing better next month, right? And so to say we got your D is low, we got that check. We're dealing with your sleep apnea check. You change your diet. You remove we haven't even talked about alkalinity, your body pH, and bone health. We didn't mention that's a huge marker, right? So let's say we're working on your urine pH because if you're alkaline, you're basically your bones are your primary buffer for your body, right? So if you're eating acidic foods, guess what? Your body's using your bone to balance that, right? So let's check your urine pH, salivary pH, right? Okay, we're doing that. Well, how do I know that's all I need to do? You can check that telepeptide level to see, is it coming down? It gets a little tricky if it's normal, then it's like, well, maybe, something else is going on in your bones. Toxins, lead. A lot of people forget about lead toxicity is a big issue with bones. And there's this interesting phenomenon when women go through menopause, they'll lose about 3% of their bone mass every year in that first part of going into it. And there's a phenomenon where you see more emotional liability. And some people actually theorize it's actually not directly the hormones, it's actually the lead being released from their bones as they're breaking down.
Like auto intoxication, basically.
Yeah, pretty much from your bones. Yeah. Which is interesting because if the half-life of lead in your bone, it's going to take 17 years for it to get out. And I do a lead level, I do provoked lead, and it's elevated. Then I have to have a 17-year program. because I might get everything, I might get your lead level down, great, but as your bones are turning over, you're gonna be releasing it. So how am I keeping that out with appropriate metals, appropriate minerals, lots of magnesium, potassium, citrate, which are great for getting out of your system, all these different things. Like it's complicated.
It is. It is. And usually, that's usually the point where, I know it sounds like you're seeing people too, is right. They're struggling. They're having these challenges. They've seen a lot of different people. They haven't been able to make sense of it all. And I think it's important when people find that shepherd that can kind of walk them through and guide them through versus trying to figure out something that's really complicated on their own. So, and then in terms of, any other things that you think are important for our audience to understand about any specific conditions, contributors to bone loss, any actionable things that you would share with them about osteoporosis?
I think the big thing I would share after this conversation, we've gone through a lot of different things, is you got to keep the main thing the main thing. It's so easy to go on these pathways and all of a sudden, oh my gosh, my lead, my inflammatory markers, my gut, and you get sidetracked. The main thing, your diet, stress, exercise, sleep, meditation, relationships, nutritional stuff, like removing chemical. These are all the basic foundational things that all the cool stuff is built on. So I so many times see people like they get stuck on the basic stuff. They don't get stuck on the fancy stuff. I have no problems getting people taking fancy compounded hormones and fancy supplements. That's easy. It's like the daily grind is where people struggle. And I think what I would just say, Kevin, is back to like, that's where people have that's where success comes from, is mastering the basics, not, I'm going to do the bone builder forte that's got, strontium in this BH, milk protein extract. I'm like, okay, cool. Like, yeah, take it. But are you still drinking Coke? Are you still smoking? Are you still eating lots of grains? Are you still doing lots of dairy? Is your gut still a wreck? Like the basic stuff, right?
Yeah. No, I would totally agree with you. A lot of people have a really hard time making actionable progress with those things, forming habits around just some of the basic stuff that they need to be doing. But this has been absolutely awesome. I'm glad that you and I had the opportunity to chat. Where can people find you if they want to work with you or want to, reach out to you or follow you? Where can they find you?
They can find me at my website, which is richmondfunctionalmedicine.com. I'm also on Instagram at RVA Integrative. But my website, I've got a lot of educational resources there. I do a blog on a weekly basis. When I do podcasts like this, I put stuff up there. But the website, I've got a book reading list of books for people to get educated about functional medicine and different stuff. So that's like my educational informational hub is richmondfunctionalmedicine.com.
Awesome. That's great. So what we'll do is we'll link to that in the show notes. And for all of you listening and watching right now, you can find all the resources, show notes, everything we mentioned today over at bonecoach.com/Aaron Hartman, MD. Dr. Aaron, thanks so much again for your time. Everyone else, we'll see you in the next episode. Hey, it's Bone Coach Kevin Ellis. Hope you found that episode helpful and that you enjoyed it. Just one last reminder, if you haven't done so already, head over to bonecoach.com, sign up for your free 7-day osteoporosis kickstart. It's going to tell you everything you need to do to start getting on the path to improvement. Hope you found this helpful. I'm your Bone Coach Kevin Ellis. I'll see you soon.